back to the recording or the template. So I'm going to hand over to Christina now. Thank you.
Great, thanks, Nisha. I'm just going to share my screen.
We have a start up there.
Oh, sorry, all these pop-ups. Can you all see the right screen?
Yeah, we can see the template.
Wonderful, thank you. Hi everyone, welcome. Thanks for joining us. Before I go into the template, I'm just going to give a quick overview of the service. So just a reminder on the aims of the service, and that's to use the community pharmacy's knowledge and your pre-existing rapport with your patients and the public to address the main barriers to childhood immunizations. So we're seeing this resurgence of vaccine preventable diseases through outbreaks, and we've got rising cases in things like measles and pertussis. And this is down to a lack of vaccination uptake. So we're trying to overcome vaccine hesitancy and try and understand the reasons for low uptake. And that's sort of the key to preventing these diseases in the population. So hopefully, once the conversations have taken place, parents will be encouraged to vaccinate their children. I think nowadays it's not just enough to tell parents, oh, it's safe, don't worry, just give your child the vaccine. We want to take a more evidence-based approach. We'll give them facts and figures and studies and science, and hopefully that will sort of bulk up the conversation and it will have a bigger impact. The service will take part in 3 stages. And remuneration will take part at each stage. So the first stage is having that conversation with mum, dad, or legal guardian. And then there's referral and booking of the vaccination. And then the last stage is follow-up. Just a really, really important note that the quality of reporting is really important to the aim of the project. Of course, we want to increase vaccination rates, but for the small majority of those that still remain unvaccinated, we really do want to understand the reasons for hesitancy so we can target this going forward in future and our engagement going forward. So now we'll go through the template. So at the top here, you have the targets cohort. So you have children aged 1 to 11 who haven't completed their childhood vaccination schedule for their age. If they have any siblings aged 12 to 19, we can also capture them opportunistically. So this is the age that we're looking to capture, and we will also circulate the routine immunization schedule in the pack that Nisha's going to circulate. So you'll have that to hand just as a refresher. So here we have the beginning of a template, the usual patient details, and then we've got the consent that we need. So I'll go into who you can refer to in a second. The first box will make sense towards the end of my part, but this is consent for data sharing to a community pharmacy. There will be some community pharmacies that can deliver the vaccinations, but I will talk to you about that in just a moment. The second consent for data sharing is to the GP, in case you refer for vaccination to the GP. And then there's also consent to access the patient's NCRS. So we need to make sure we've got yes for all of these, or the template won't let you continue, is my understanding. Next, we want to know who the conversation is taking place with, mum, dad, or legal guardian. And yeah, if you could just pop the answers here. And this is the next part. If you click yes to the patient being up to date with their vaccinations, you'll get the small supplement payment. So it's a small payment for those that are fully vaccinated, because you're not going to have that conversation. And if you click no, that's when the larger remuneration will take place, because that's when you're actually having a conversation, and this will open up the rest of the template. But if you click yes, we still want to capture these patients also, but obviously more so with no, obviously depending on whether the child is vaccinated or not. We also want to know if interpretation services are needed. So again, if yes, please let us know which language. If no, that's fine. And it can be done by a pharmacist, pharmacy tech, or a HCA. But if it's done by a HCA, we ask that there is oversight by a pharmacy professional. Okay, so MMR screening. So the majority of the consultations will sort of focus on MMR and polio. And we'll opportunistically just do a quick check on the rest of the schedule. But the main bulk of the conversation will take place around MMR and polio. So let's show you what it will show you. So is the child age 12 months and above? We'll click yes, for example. And has your child have had their first MMR vaccination? We'll click no. So when we click no, you'll get the whole bunch of reasons for not having the uptake of the vaccine. And you can click more than one here. If you click, say, for example, safety concerns over autism, you will get your supporting evidence to support your conversation. So here is the sort of science, evidence-based information that you'll need to have that conversation. Just a point of note, you don't have to use this information to have the consultation. Some parents might just be okay to be like, I just want some reassurance, just, you know, and they just want to have a conversation over something, say, for example, like a side effect. Maybe they're just worried about side effects. Some parents may want some real science evidence to support. So as the sort of provider of the service, try and gauge what mum or dad or legal guardian need to support that conversation. You don't need to use this, but you may need to. You can also click on, we've given you the links as well. Some parents might want a printout, for example, of the studies. I don't imagine they all will, but some may do. And that's something you can provide also. So I don't know, say, for example, religious beliefs. We've got here things about, you know, gelatin, porcine products and things like that. So everything is tailored to each reason for hesitancy. If, for example, we haven't thought of a reason, please click Other and give us as much detail as you can. So that will help us with our evaluation and for targeting these reasons going forward. And this will be the same for the second MMR, but you won't need to repeat it because it's either or. Please don't be overwhelmed by the template. You don't need to click everything. It's just we've had to cover all our bases. And again for polio. So if we click no, they haven't had it. Again, you've got your reasons to support your conversation, but it's much smaller than MMR. So having a conversation around polio shouldn't take as long. So these are the real concerns. It's either safety concerns over side effects or safety concerns over neurological conditions. Again, if there's something we haven't thought about, please pop it in the other box. And just moving lower towards the rest of the screening. Here, we're not going to give you any evidence because otherwise the template will take too long. It's just a matter of making sure they've had their IMS. So this is MNB, rotavirus, so on and so forth. Just please click as and when is appropriate. Okay. And then follow-up vaccination. So this is now we're approaching stage 2. After having this discussion, would you like to book an appointment? Hopefully it's a yes. Okay, here you have the option to either refer to GP practice or pharmacy. There will be some pharmacists across Southwest London, a small number of pharmacies that will be delivering an NHS England commissioned service to deliver MMR vaccines. And here you have the option to either refer to these pharmacies, and we will show you how, and we will tell you who they are later on in the week, or you can refer to GP practice. If you refer to GP practice, Pharma Outcomes should give you a template. It will sort of design a template and you can send it directly to the GP. If it's to the pharmacy, we'll give you a step-by-step guide how to do that. You'll need to do that slightly more manually, but we will give you the guide on how to do that towards the end of the week. And then just click whichever ones need to be given. Any further information you can also add, and that will go to the GP as well. Let me just show you. So this is the main bulk of, so this is stages 1 and 2, so consultation and referral, and I will just show you the follow-up template as well. So this will be in a separate template, so follow-up. Okay, so this is stage 3. So hopefully the child has gone and had their vaccine, and we just need you to enter it to get that final sort of payment. Have vaccines been given? Hopefully it's a yes. And please select which ones have been given. And then also we're just going to ask you to confirm on NCRS as well. So hopefully that's a yes too. Nisha, Amit, have I missed anything out?
No, Christina, I think that was quite good and yeah, in depth. Thank
Awesome.
you.
Thank you.
Does anyone have any questions regarding the template? As Christina said, it looks quite overwhelming and complicated, but actually when you go through it, it's not that bad. And we've had a pharmacist look at it and we've had a few iterations. So we're just hoping that it's all run smoothly. Okay. If no one has any questions, I'm going to hand over to Tara, Liz, and Emily from Croydon Health Services to take us through the bulk of the session. Thank you.
Thanks so much, Nisha and Christina. Emily, would you mind sliding the shares or sharing the slides, please? It's hot. Thank you very much. And we will introduce ourselves. My name's Taraka Elliott. I'm actually a children's palliative care nurse by background, but have been vaccinating alongside doing a PhD since COVID. I started vaccinating just thinking, oh, it will be temporary through the COVID campaign, but actually have really fallen in love with working for the service, and COVID turned into monkeypox, turned into flu, turned into hepatitis A, and now here we are, unfortunately, talking about kind of the resurgence of vaccine preventable illnesses in children. At Great Ormond Street, I do a lot of teaching and thinking about having difficult conversations, and there's quite a nice overlap with what we're thinking about today. Liz, would you like to introduce yourself?
Yes, thank you, Tara. Good evening, everyone. My name is Liz Ray. I am a nurse by background. I've worked in hospitals and also in general practice, more recently as a nurse practitioner, and I've worked with the South West London Immunisation Service since we started vaccinating back at the beginning of 2021. I say vaccinating for the COVID programme, and as Tara says, we've now extended to many other things. And more recently, I've taken on a role of the training and of new staff coming through, which has extended to workshops such as this. So nice to meet you. Thank you.
Thanks, Liz. Emily, would you go on to the plan for the session slide, please? I think it's either the next one or two ahead. So just going to kind of talk about what we have planned between now and 8 o'clock. Also wanting to recognise that there will almost definitely be a range of professional backgrounds in terms of people on the call. For some people, some of what we talk about will be revision and things that you know well. For others, there might be parts of today's session that will be new. And we do want to give people the opportunity to ask questions and discuss, particularly in the second part of the session. We will have a very quick 5-minute break between the first half and the second half. Neither Liz or I claim to be immunology experts, and I would never claim to be an expert in communication because I get that wrong a lot. But I do like to try and think about how we might recover and repair conversations that are going wrong. What we plan to do in the first half of this session is to give you an overview of childhood immunisations with a particular focus on the MMR and polio vaccines, but also to give you information about those illnesses, because certainly when we're thinking about parents and many parents of young children won't actually know what things like measles and polio are. And then in the second part of the session, we're going to think about barriers to vaccination, enablers, and just some of the things that might influence decision making when parents are invited to vaccinate their children. So that is the plan for the session. And with that, I'm going to hand over to Liz, who will take us through the facts about illnesses and vaccines.
Okay, thank you,
Please.
Tara. Next slide, thank you. Great. Okay, so let's start off with measles, and thank you for bearing with us on this very hot evening. The information that I've got to just go through with you now is, as Tara puts it, the slightly more meaty information. If you want to ask any questions, just pop your hand up and we can certainly answer them as we go along or at the end. So I'm just going to have a quick overview of firstly the mumps, measles, rubella and the vaccine, and then polio. So from October last year, as you can see on these slides, and sorry, I will just add at this point, if it's not been said already, we can send you a copy of the slides. So please do not frantically write all of this information down thinking you're never going to see it again. And please understand that we appreciate there's a real range of professionals here. I mean, some of you will have all of this knowledge, I'm sure, already, whereas for others, a lot of it may be new. So I've just tried to base it as fairly generally as I can. But our work with measles started last year, essentially, because since October, 1st of October, there has been a real increase in measles in the UK, with 2,154 laboratory confirmed cases since then, with 173 in the last 4 weeks. And that's quite important because measles is a notifiable disease, and these are the cases that we know about, but there will of course be, I'm sure, more than that. And 53% of these cases have been in London, and most of them are in children under 10 years. So by comparison, in 2022, there were only 54 cases in total. So you can see that is a big increase. Now, essentially, we think this has occurred because of low vaccine coverage in many areas, particularly in London. And if an outbreak were to occur, there could be up to 160,000 cases, which would obviously result potentially in a number of deaths and big strain on our NHS. And these rates have lowered because essentially of COVID-19, people not being able to attend, vaccine hesitancy, and just vaccine fatigue. And in addition, there is the Wakefield cohort that we will go on to talk about, which are 16 to 25-year-olds who were affected by the Wakefield study and who either only had one or no vaccines. So once we had this increase in measles, we worked really hard to ensure that those young people who have missed their MMR vaccine came forward and had it. And there's been a lot of work going on in contacting parents via GPs, doing all sorts of outreach work. And certainly the first 3 months of this year, our MMR rate has increased by about 23%, with over 360,000 vaccines being delivered, MMR vaccines. Tara and I started doing this work last year because we were asked to go out to reach some of the local community workers, some council workers, people working in housing offices, staff working in early years centres, to try and help them upskill them with regards to their knowledge of children's vaccines, and again, how to try and talk to some of the people that they were seeing in their everyday work, because a lot of the people that haven't been vaccinated are those vulnerable people, possibly from overseas, and if they're seeing their housing officer and they haven't got anywhere to live, the MMR vaccine is probably going to be the last thing on their mind. But these local authority and council staff very much build a relationship with these families and have the opportunity to talk to them. And I appreciate that also many of you working in pharmacies will build relationships with your local communities and are in a very favourable position to have conversations. Thanks, Emily. So just moving on to what is measles, I think Tara may have mentioned earlier, but generally we don't see measles in our professional lives. I've worked in general practice for a number of years, have never seen measles, and the same with a lot of GPs. And Tara was saying that in her work with paediatrics that she's probably only seen it once, but it is there, and it's just something that is more difficult to diagnose because we don't see it all day, every day. And these slides just show the rash essentially that occurs with the measles disease, and I'll refer to them in a minute. But basically it spreads very easily and can cause very serious problems in some people. And the symptoms are essentially cold-like symptoms, so including a high fever, a cough, and very often accompanied by conjunctivitis. And that's often a giveaway in that the conjunctivitis can differentiate measles from other flu-like type illnesses. A couple of days after this, what we call prodromal period, the rash appears, and it starts on the face, spreads, so it's behind the ears and spreads down over the trunk. And it's very different from, say, the chickenpox, which is a number of individual spots that are itchy. The rash is a red, raised, blotchy rash, and you can see it more clearly in that fourth picture. The second one, where we've got a darker skin, it's less obvious, more difficult to see, but you can very much feel it, and you'll feel the texture of it if you do touch it. Now, the other thing that you may see is something called Koplik spots, which appear in the mouth, and the little white bluey spots that also are an indication that you should certainly be considering measles. Don't always get them with measles, and occasionally you can get them with other diseases, but with the rest of the history, that's a pretty good indication that that's what we're looking at. So the infectious period tends to be before the rash comes out, about 4 days, and the individual will remain infectious until the rash subsides, or 4 days after its initial onset. And incubation period is around 10 to 12 weeks. So in a school or nursery setting, if a child is thought to have measles, it will be up to 2 weeks before we know whether anybody that's been in contact with that individual has got measles. Essentially, about 9 out of 10 people, if they're in contact with somebody who has measles, will get it if they're not vaccinated. So it is very infectious. And like COVID, you've essentially got to be in close contact for about 15 minutes. So certainly a nursery or school setting is an ideal place for it to spread. Thanks very much, Emily. This photo is the Koplik spots. So you can just see they're found on the inside of the mouth or the cheeks. And you can just see there those little white spots that appear essentially in the prodromal period before the measles rash. Thanks very much. Next one, please. Okay, so just a few facts about measles. About 1 in 5 children will require a hospital visit if they become unwell. So fairly high rates of visits to hospital. And as I said, 9 out of 10 children will catch measles from an infected classmate if they're not immunized. And about 1 in 15 children will develop a serious complication. So these include meningitis, blindness, pneumonia, or SSPE, which is subacute panencephalitis. And this essentially will lead to coma and death, and occurs in about 1 in 1,000 cases. So if you think of us having an outbreak of 160,000 individuals, that would be a significant amount of deaths. And interestingly, I was on holiday earlier in the year, and I caught up with a friend who I haven't seen for many years, and we were just sort of exchanging news and, you know, what had been going on in our lives. She was an old nursing friend who'd moved out to Dubai, and she was telling me that she had adopted a girl from Ethiopia, along with a very good friend of hers had adopted a boy. And she was just saying that very sadly, the boy, age 15, had just died of measles. And of course, my ears pricked up to find out a little bit more about it. And he had measles over in Ethiopia. This was the resulting story, but they didn't know that. And when he seemingly had recovered, but when he came over to Dubai, he was given all of his childhood immunizations. So he was given an MMR vaccine, but of course he had already had measles. Now that wasn't an issue that wasn't a problem at all. But what he did then develop was this neurological symptoms, which eventually resulted in coma. And after about 5 years, he died. And that's this SSPE, and usually will always lead to death, but it is a very slow deterioration of neurological symptoms. And as I say, it was found to be from measles, but it doesn't develop until usually about 7 or 8 years after you've had the illness. So it's very interesting to actually hear of a case of this, and of course very sad. There is no medical treatment for measles. Vaccination really is their best protection against severe disease. And just a couple of facts about pregnancy, because it is a live vaccine, and I'll go on to talk a little bit more about it. It can't be given to women in pregnancy. So now with preconceptual counselling, if somebody is planning a pregnancy and they haven't got protection, particularly against measles, we would offer them the vaccine and ask them to wait for 3 months before trying to get pregnant. And what else have I got there? Breastfeeding is not a contraindication to vaccinating the mum. So if mum is found not to have got immunity to measles, we would always recommend that she has that as soon as she's delivered. So the vaccination schedule for measles, or MMR, starts at a year. We do the second dose at about 3 years, 4 months, although in Wandsworth, we do it early at about 18 months. It's one of the boroughs that have elected to do it early, and there's no reason not to do that second dose early. But it mustn't be given before the age of 6 months. Occasionally, if somebody is travelling and they're going to a country where measles is known to be a problem, the vaccine can be given before a year. So it can be given from 6 months if early protection is needed. But the response is usually suboptimal, and so it will be repeated once they reach a year. Thanks, Emily. Okay, so just a little bit of information about the vaccine itself. It's a combined live vaccine, so it is a very weakened strain of each of these 3 diseases, and it's been in the childhood immunisation schedule since 1988. And as I've said, first dose at a year, and then nationally we give the second dose at 3 years, 4 months, but it has to be at least 3 months after the first dose. So there are times when we do give it earlier. And 2 doses provide the best protection against all 3 diseases, with over 20 million measles cases being prevented in the UK if everybody comes forward and is vaccinated, which is roughly 81 lives a year. It's a free vaccination on the NHS, and vaccination's efficacy is very good. It's 99% for measles and rubella, and about 88%, I think, for mumps. Thanks, Emily. So it is a very effective vaccine against the diseases, or indeed, if you do get any of the diseases after vaccination, then it will be much, much milder. Okay, protection starts around, well, as soon as you have the vaccine, but will take about 2 weeks to before you've got good immunity. Thanks, Emily. Okay, so just a little bit about the side effects. In general practice, when we give the MMR vaccine, we always give the patient information leaflet, because there's a lot for parents to remember after they've had the vaccine, and often parents are anxious and don't retain the information that we give them at the time. Because it is a live vaccine of 3 different diseases, each of those diseases can have side effects with the vaccine at a slightly different time. And so there you may get a rash, which tends to be the measles part of the vaccine at sort of a week or 10 days. You can get some swollen glands, which is the mumps part, and you can get some joint pain, which is usually from the rubella part. Initially, the child obviously may cry and be upset after the injection, but they usually settle very quickly. There may be some redness where the needle's been in, the same with all vaccines. And again, 7 to 10 days, they may get a high temperature. As I say, we give them the patient information leaflet so that parents can look at that and see whether, or if they've got any concerns, and hopefully be reassured if they get any of these side effects. And if they got a rash because of the measles vaccine, they wouldn't be infectious. There's no reason why they wouldn't be able to go to nursery, etc. So it's just as a result of their body processing the vaccine. And in practice, it's about 5 to 15% of children will get these mild diseases resembling the MMR diseases, get mild symptoms. And it's usually after the first dose and much less likely after the second dose. And it's always good to reassure parents that any possible complications of these conditions are much more serious, or indeed their viral count, obviously, if they were actually to contract measles, would be far, far higher than any small weakened strain that's used in the vaccination. And just to let you know that one of the vaccines has got pork gelatin in, which may not be acceptable for everybody. This is used to maintain stability of the temperature of the vaccine. But Priorix, which is the other MMR brand, doesn't contain the pork gelatin, and this is readily available. So it is something that can be offered if that's an issue. Thanks, Emily. Just very quickly, a little bit about the testing for measles. If measles is suspected, essentially we would request a test from the Health Protection Agency. And this is a swab where you swab the inside of the mouth, and the test is sent out to the individual and returned fairly quickly, so that we can get a result as to whether or not, in fact, it is measles. And if measles is suspected in somebody that's not vaccinated, that individual must be isolated until we have the results of the test. You can do it up to 2 weeks after onset of the first symptoms. But as I said, any individual would need to be excluded from school, nursery or work, certainly until their symptoms have gone. If outbreaks occur in school settings, then any students who are susceptible or not completely vaccinated, they will be offered the MMR vaccine, even if they haven't had direct contact with the case. And indeed, if they have had direct contact with a case, it is absolutely fine to go ahead and vaccinate them. Thank you, Emily. Okay, so that is the measles part of it. Just before I whiz through a little bit about polio, has anybody got any questions or anything that they want to ask, please? Have I stunned you all into silence on this hot night?
We've got a question. Yeah.
Thank you. Hi, is it Arundhati? Do you want to go ahead? Hello? Sorry, do you want to just take yourself off mute? I can't see you on your camera. But is it Arundhati? No? Can you hear us? Ah, here we go. Hello there. Have you got a question for me? I wonder if they're having a little bit of trouble. Okay.
Aru, are you
Anybody
able
else?
to put your question in the chat if your mic's not working? Thank you.
We can always come back to you a bit later. Anybody else got anything that they would like to ask at the moment? Okay, so let's
Liz,
yes.
Liz, there's another question in the chat, which is, are schools and nurseries obliged to keep vaccination records?
I don't know that they're obliged to, actually. I don't know the answer to that. Usually when registering in nurseries, they are required to say whether or not they've had their vaccine, so that obviously in a case like this, or sorry, if there is an outbreak, then they have the information to hand. And the school nurses certainly from school age will keep records of all of the children's immunisations. So I suspect it's up to the nurseries themselves. I don't know whether they're obliged to, I don't know whether it's mandatory. I would suspect so in the cases of an outbreak. Would you agree, Tara?
Yeah, I think it's just, it would just be about who discloses that information, because obviously parents can choose to disclose or not. And obviously there isn't one kind of child record that goes between schools and health.
Okay.
Arundhati, you've appeared on camera. Are you able to? Oh, what brand of MMR vaccine is used for routine immunisations?
I think to be honest, it tends to be whichever you can get, either the MMR2 vaccine or the Priorix, whichever one you can get from Inform usually. So it's just that the Priorix one is the one without the pork gelatin, and usually, certainly in general practice, we make sure that we've always got a few of those and use that if necessary. But to be honest, it usually just depends on whatever's available and whatever we're sent. Okay. So let's just have a quick look at polio, which is a highly infectious viral disease this time that largely affects children under the age of 5 years. And the reason that we started that it sort of reared its head again was between February and November 2022, some wild polio viruses were found in sewage samples in the London Beckton sewage works. And this was just following some routine surveillance, but it was thought that these wild polio viruses could potentially cause serious illnesses, such as the serious symptoms of polio, such as paralysis in people who were not fully vaccinated. So transmission for polio occurs essentially from person to person, mainly through the fecal oral route. So essentially from poor hand washing, where if you're putting your hand then to your mouth, it can be transmitted that way, and occasionally through contaminated food and water, and rarely through coughing and sneezing. That's really much less common. So essentially the symptoms of polio are fever, fatigue, headache, stiffness of the neck, limb pain, and vomiting. And these symptoms can extend to an irreversible paralysis in the case of about 1 in 200 infections. And we don't tend to see polio nowadays, but you may in the past have seen people in wheelchairs who are there essentially because they've got polio. 5 to 10% will die because the breathing muscles are affected, and they can't then maintain life. So nowadays, it's a fairly low risk in the UK due to the very good high vaccination rates. And polio was essentially eradicated in Europe in 2003. There were three types of wild polio viruses, and 2 and 3 were eradicated, but type 1 remains endemic in Afghanistan and Pakistan. And because of this, it is a global risk, and there is always the risk of importation and resurgence unless we completely eradicate it. So when this wild polio was found in the sewage works, it was in an area of London essentially where immunisation rates were low. And as a result, it was felt that everybody in London should be offered an extra polio vaccine or booster vaccine, and parents were encouraged to check their children's red book, check that their children were up to date with their polio vaccines, and we offered an extra vaccine to all children aged 1 to 9. Now, no clinical cases were identified during this time, and the risk to the wider population was assessed as low. But because it is such a preventable disease, one case of polio ending in a paralysis is one case too many. And so for that reason, everybody was asked to come forward and have the extra booster. Thanks, Emily. Lovely. So one of the reasons that the polio was potentially found in the sewage was because in some countries still they use the live polio vaccine. We use the inactivated polio, so it's part of our routine childhood immunizations. And we stopped using the live vaccine in the late 90s. And some of you may remember that if you took your child for a polio vaccine at your GP practice, you were asked to be very careful changing nappies for about 6 weeks afterwards. And that was essentially because of the transmission from fecal route, that you could essentially, if you didn't wash your hands properly afterwards, transmit live polio. And this is one of the reasons why they think they found wild polio in the sewage. But as a precaution, as I say, this extra vaccine was offered. And these at the top there, you can see, are the immunization rates in London generally, that the 3 vaccines that children should have had by the age of a year, there's only about 87.6% of children have received them, and even less for the preschool booster, which is given at age 3.5 years, so less than 70% in London. I think I've whizzed through all of that actually, pretty much. Thank you. And just with regards to polio, as I was saying, the main complication is this paralysis generally of the legs, of the lower part of the body, for which there is no cure. And I'm going to show you an interesting slide afterwards that just is about living with polio. And so it's treatment of the symptoms, and obviously long-term complications of paralysis, muscle weakness and swallowing difficulties are the main issues. And once you've had polio, there can be a recurrence or worsening of symptoms decades later. And it isn't something that we essentially see now, because when vaccination started in the 50s, the cases came down very dramatically and very quickly. But if I can have the next slide, Emily. I just wanted to share this with you because this story is just quite interesting. And this gentleman died earlier this year at the age of 78, having spent 72 years in an iron lung. When I used to work at St Thomas's Hospital, we had a ward there called Lane Fox, which was full of these iron lungs. And we had polio patients that would come in for weeks or months at a time to spend time in the iron lung, which would give their breathing muscles a rest essentially, and then they could live normally or more normally for periods of time out of the iron lung. So this gentleman, Paul Alexander, got polio at the age of 6, and then he was placed in this iron lung machine that encased his whole body, which is what was used then. And it's a negative pressure system that creates a vacuum to force the lungs to expand and contract. And as I said, patients would spend periods of their life in these machines. But he was very reliant on it, and as a result ended up spending the rest of his life, 72 years, on and off in the machine. They were very popular in the 50s and 60s before polio began to get under control, and were gradually replaced by positive pressure ventilators. But some people really struggled to move over to the modern ventilators, and there is still one lady in the States who is using an iron lung. Paul Alexander was recognised by the Guinness World Records for spending the longest time in an iron lung, and he started more recently a TikTok account and had over 330,000 followers. And there was quite an amusing bit when I was just reading up about this, about his life, and how he did manage to qualify as a lawyer and have his own practice. And he would spend long periods of time in his iron lung. And clients would have an appointment to see him would arrive into his practice, and he would be there in his iron lung. So they would get a bit of a shock. But it's I mean, you know, you have to have huge admiration for this gentleman who lived his life like this for many decades. And I just thought it was good to show you this, because it just reminds you of the dangers of diseases such as this, and how, and you know, the impact that they can have on your life. Thanks, Emily. Okay, so just very briefly about polio vaccination, that pre-vaccination, there are over 8,000 cases a year with about 750 deaths. And the last outbreak we had in the UK was in the 70s, and the last natural paralytic case was in 1984. So vaccination was introduced in the mid-50s, and essentially, as I said, in 2003, the whole of Europe was completely polio free. But because now there is this wild virus that's been found in some of the sewage, we're not quite back to that situation, although things are significantly better since we've had this latest polio booster. So polio is given by injection. It's given at 2 months, 3 months and 4 months in the routine childhood vaccination programme as part of the 6-in-1 vaccine that's given to babies. It's given again before attending school, and then at age 14 as the final school booster. And once you've had those 5 vaccines, you will then have lifelong protection from polio. It's not necessary to have any more, although you may end up getting a booster if you, for example, have a tetanus vaccine, because the tetanus, diphtheria and polio come together. So that's that. Thank you, Emily. Just very quickly, side effects of the polio vaccine really are not, there's nothing specific. It's just the same as any of the routine vaccinations. Children can get some soreness at the injection site or be a little unsettled, may get a temperature. Generally, we advise giving them Calpol if necessary, as long as they're at least 2 months old. And older children may get fever, tiredness, muscle aches, and just be a bit out of sorts. The vaccine is very effective. It will protect against severe disease in 99 out of 100 people who receive all doses, and even 2 doses will give at least 90% protection. But the further doses tend to boost that protection and give longer lasting protection. And the only people that really shouldn't have it are those with known allergies to any of the antibiotics listed there: streptomycin, polymycin, neomycin. Thank you. So I think that's all of the sort of nitty-gritty stuff. I've just tried to whiz through it as quickly as possible for you, because I realise that you're all at the end of a long day. Is there anything that anybody would like to raise, or any questions just about any of that before we stretch our legs for a few minutes? If you think of anything, as I say, do feel free to put it into the chat, and we can make sure that we get back to you with your answer. Tara, is there anything else to add at the moment?
No, I don't think so. And nothing new in the chat. So I suggest we have a really quick 5-minute break, stretch your legs, grab a cold drink. And when we come back, we will be thinking more about the decision-making and communication aspects. Okay, thank you very much. Oh, there's one question. Do children who've had both doses of polio need another?
Yes. That have had both doses, did you say?
Yeah, that's the question.
Okay, so yeah. So as I say, the childhood immunisation schedule is 2 months, 3 months and 4 months, and each of those vaccines include the polio. So that's the 6-in-1. So they need to have those 3 plus a booster before they go to school and a final one before they leave school. All of the children in in 2022 were offered an extra vaccine. So those that were 1 to 9 were offered an extra booster vaccine because of this polio that was found in the sewage. So they would need to have all of those vaccines. Now, sometimes people come from overseas and they have slightly different schedules. And so we tend to transfer them onto the British schedule. And if in doubt, we would always actually offer the vaccination. We would tend to, if there's any concern at all about how many a child's had or whether they've missed, then we would always recommend that they do have extra doses. But we do have a chart that we can look up and we can compare, and we can essentially discuss with the parent whether or not something's needed. Does that answer the question? Hopefully.
Thank you, Liz. And there's another question, just clarifying that the SSE or the encephalitis can appear up to 7 years after measles.
Yes, and in fact, it may even be a bit longer.
I think it's longer,
absolutely. Yes, it may even be 10. It's a significant amount of time. Symptoms can, start at any time, but it can be much later. And that obviously is the very scary aspect.
Thank you.
But it is rare. Thank you.
Thank you very much, Liz. Okay, so I suggest we come back at 8 o'clock for the second half of this session. Thank you very much.
Lovely.
Okay, great. So welcome back. If you're able to pop your cameras back on, just so that we know everybody's ready to restart, that would be really helpful. Lovely, thank you. If you're just coming back, I was just asking for your cameras to be turned on. Okay, thank you. If for the message about your camera not working, that's fine. I do understand, but yeah, if your camera's working, you're able to just put it back on. We know we're ready to start. Thank you. So before I start sharing the slides, or Emily starts sharing the slides again for us, I just wanted to have a think together about maybe what are some of the barriers or objections to vaccination that you maybe have heard parents say to you, or you've read on social media. What are some of the things that get in the way of vaccinating? And I guess as we're doing that, I find it helpful to think about the barriers that might come from individuals, from society, from us as professionals, and maybe at a service delivery level. And I'd love to hear from you.
I think the autism fear was a big thing some time back, and probably still is, I think.
Excellent. Thank you, Juliet, for going straight to the big one, which is the link that one team claimed to find between the MMR vaccine in particular and autism. Brilliant, thank you. And so a couple of people have said that. We're going to come on to the autism thing in more detail in a minute. What else?
I think some people might think it's not relevant anymore because so many of the illnesses are, you know, the numbers have gone right down. So a lot of people probably think that it's not relevant to still have the vaccinations.
Yeah, great, thank you. So as we've already said, most people don't know what measles and polio are. As Liz said, I've been a children's nurse for 30 years, and I've seen my first case of measles at work within the last 3 months. I'm also old enough to remember having measles, but many people won't have that experience. Again, older people will remember what it was like to have friends or siblings in iron lungs. But actually, nowadays, a lot of younger people won't know about that. So we're asking people to vaccinate against illnesses that they maybe don't know about, don't understand what the risks are. Either they don't know about it, or they think, well, what's the point in vaccinating, because no one gets that. So that can't be a risk. Thank you. So another comment in the chat, side effects. And that can range from somebody being really, really worried about a side effect being something life-changing like autism, or life-threatening like anaphylaxis, through to actually my baby was really miserable after the last 2 vaccines, and the appointment they've sent me is the day before we go on holiday, or the day before a birthday party. And so actually I just don't want to take the risk of, although I know they're mild side effects, I just don't want to take the risk of those side effects ruining whatever plans that we have as a family. Influencers on social media, yep, so absolutely. Conspiracy theories, any comments on social media, and they can be really, really forceful and powerful comments. Last Saturday, Liz and I spoke to a group of parents at a children's centre in Wandsworth, and the session had been advertised on Nextdoor on Facebook, and it was advertised as a kind of a place that parents could come for CPR training and a talk about vaccines and a free lunch. And the first comment on that Facebook post was an anti-vaxxer talking about vaccines being full of poisons. So DTP people are asking about whether combined vaccines are available as individual vaccines is really relevant, and we'll come on to that why in a few slides time. But that might be somebody who isn't anti-vaccine, but actually is picking and choosing which vaccines they want for their child by thinking about maybe what the child is most at risk from, and so kind of like being a little bit more selective. And yeah, the kind of time gap between MMR and live vaccines, and some parents will just worry about how many vaccines we're giving all in one go. Anything else? Lizzie, you've got your hand up.
Yes, I was just going to direct you to the questions in the chat. Just with regards to the DTP, if it's available as individual vaccines, it used to be. We used to give all of those individually, and now if you need a tetanus, you get a DTP, the same as if you need a polio. There is only the 3-in-1 vaccine for DTP. But yes, I was just going to say fear, Tara, is a big issue, isn't it?
Yeah, and we'll talk more about fear again in a minute. Thanks, Liz. The vaccine fatigue, absolutely. So, if you ask people how you're feeling about vaccines, and we did this with the parents we were talking to about talking to on Saturday, and actually people who used to be completely fine with vaccines and now just feeling there's just so many vaccines. And parents of young children have had the COVID program, then they've had the extra polio, and now they're having information about measles and whooping cough in particular. Sometimes it might be the way that our services are delivered, or how vaccines are offered. So, for example, my children were offered a flu vaccine in school at Christmas last year, and I am someone who I'm very unquestioning when it comes to vaccines. That's my personal position. I'll sign anything. But on the day that the vaccines were given, my daughter missed her flu vaccine, and for a couple of days I thought, right, I must find out how I can get Nancy's flu vaccine. And actually, coming up to Christmas, it just slipped down my list of priorities, and she didn't have it because no one contacted me to say she's missed her vaccine. Would you like a catch-up program, or this is where you go? And I just wasn't proactive enough to pick up the phone or go onto the internet and find out how. And that's because she actually hasn't got any underlying health conditions, and I wasn't particularly worried. If my son had missed the flu vaccine, he has quite bad asthma, and so my motivation for getting that vaccine would have been greater, and I'm pretty sure I would have found the time that getting the flu vaccine would have stayed quite high on my list of priorities. And also, are our services accessible? Last year, I helped with an MMR catch-up campaign in a different part of London, and it was held in a big football stadium, and balloons and kind of like face painting. It was meant to be something that was going to be attractive to families, but the catchment area was so big that we were asking some of these families were having to get 2 buses, single parent families with 3 or 4 children, young children. That people are only going to do that if they're feeling very motivated to get a vaccine. If they're a bit hesitant, sitting on the fence, worrying about other things, they're probably not going to do that. So I guess that's part of what we're doing with this campaign, with this program, is trying to make things more accessible and conversations more accessible. And sometimes I think maybe, well, I don't know about you, but sometimes I think I might have been a bit of a barrier in terms of enabling people to get vaccines. I'm someone who doesn't retain scientific facts very well. So all the information that Liz has given you, the reason why she does that part of the session is because statistics just seem to go in one ear and out the other. And that can make me quite anxious. If I'm then confronted with a parent or a patient who really wants scientific information, it can make me quite anxious that I can't remember that. And we're all different. Everybody will have different strengths and weaknesses, and I know that in the past I might have avoided some of those conversations, and I think I've got better at being able to say I don't know, and finding a friend who might be more suited to that conversation. So Emily, has anyone else got anything they wanted to add before I start sharing slides again? Okay, Emily, if you could start sharing slides from the objection slide, please. What we will do now is go through slides about continuing the theme of what we've been talking about, and then thinking a little bit more about how we might, some communication tips. And then hopefully we won't stop the slides again, and hopefully we'll have time at the end for questions and kind of reflections, comments from the group. So these are some of the things that I've heard people say. It'll make their own immune system weaker. They've already got natural immunity. Healthy children just don't need them. So my cousin's got a little boy, and her husband has said he's not having all these vaccines. He doesn't need so many vaccines. He's healthy. He can fight these illnesses himself. And then her husband has gone a step further and says, actually, this is about the government. This is about the government and the pharmaceuticals. They're in cahoots just to make money. They're making money out of this. He doesn't need them. I don't trust the government. So if we're not trusting the government, and to be fair, you know, with things like the COVID inquiry playing out quite publicly, there are reasons why people might not trust the government, might not trust the kind of authorities, the information that they're being given. Sometimes it's really, really deeply held views that come from either our culture or faith or worldview, where actually this isn't about the MMR vaccine and autism, or this isn't about COVID. This is about a kind of firm stance, a non-negotiable position of not accepting vaccines. And we've already talked about the side effects. The very first comment that was made in terms of when we think about barriers was about autism. And I'm now going to hand back to Liz, who's going to take us through a couple of slides focusing specifically on that now widely discredited study that claimed to find a link between autism and the MMR vaccine.
Okay, thank you, Tara. So I'm just going to whiz through this study that was written up in The Lancet about MMR and autism, because I think it's really helpful to know a bit more information about this particular study. So in 1998, Dr. Andrew Wakefield and some of his colleagues, 12 colleagues, had this article published claiming that the MMR may cause autism, the MMR vaccine, sorry, may cause autism. And straight away, MMR rates began to drop. Understandably, people were very concerned to hear this. And as a result, further studies in the UK were immediately conducted and published, and no link was found. However, the damage was done and people had become incredibly nervous. The only thing that they could find, the further studies that were done, was that both events, the vaccine, the first vaccine, and symptoms of autism occur together in early childhood. So it was highlighted that this study was a very small study. There was no control group, and many of the co-authors then retracted their links with the study. And over the next number of years, the study was replicated in all parts of the world, and there was no evidence again of the MMR vaccine and autism. And eventually the paper was retracted, but this was 12 years later. It wasn't retracted until 2010, by which time many people had not come forward. Parents actually were not vaccinating their children because of the fear of the risk of autism, and therefore there were outbreaks of measles. There was one in the UK in 2008 and 2009, as well as pockets of measles in Canada, in the States, and various other countries. And a huge amount of money was obviously spent on further studies trying to see whether or not there was any basis to this paper at all. Now, eventually, there was a trial, and in 2010 Wakefield was found guilty of deliberate fraud. And what had actually happened was there were a number of parents that felt that the vaccine had caused autism. Some of them hadn't even had a diagnosis of autism, but the drug companies paid Dr. Andrew Wakefield to put together this study basically indicating that the MMR vaccine could cause autism, and this is in fact what he did. And the GMC found that he had been dishonest in his research and acted against the patient's best interests, and failed in his duties as a responsible consultant. And 3 months later, he was actually struck off the medical register. So as a result, the MMR vaccine is probably the best researched vaccine in the world. Several people at this time came forward and had single vaccines. I gave my son his first MMR vaccine, and then he went on to receive a diagnosis of autism. And I became incredibly anxious about going ahead then and giving him the second one. And I sought out a single measles vaccine, but they weren't available on the NHS. They hadn't had the same amount of research, the single vaccines. And also it meant that you would have to come forward and have 6 vaccines on different occasions rather than just having 2. And as a result, there were a lot of children in that cohort that didn't ever come forward and have either a first or a second vaccine. And I'm pleased to say that, you know, my son is doing very well. He's at university. He's had a lot of intervention, but it was an incredibly worrying time. And on reflection, I know that those symptoms were all there way before actually he did have that first vaccine. But it was a scary time. And there were lots of families out there that were very scared about coming forward for the MMR. There have been some studies where they've looked at the brains of children aged 6 to 12 months, where siblings have been diagnosed with autism, so older siblings, and they know that it is potentially more likely that a sibling may have autism. And so they then looked at the brains pre and post the MMR vaccine, and then followed up whether they went on to develop autism. And there was no changes. There were changes certainly in the brains of the children that had autism, but nothing in relation. There was no difference as to whether or not they had the MMR vaccine. So that was just a very interesting piece of research that has also been performed. And we need our MMR rates to be at 95% to ensure herd immunity, because anything less than that could cause an outbreak. And because it is a triple live vaccine, there are some individuals who can't have it, those that are having chemotherapy or very immunosuppressed. So that is the background of autism. If I can just have a look at the next slide, Emily. I'm not sure if there's anything else much on there that I haven't covered. I think probably that just summarises what I've said, that autism doesn't have a single cause. We know that usually it's influenced by genes, family history, prenatal exposures and a child's environment, but there isn't one specific cause. Anybody got any questions or anything they'd like to say about that? I don't know whether that clarifies any points for anybody. Hopefully it does. But if there's anything that anybody wants to add, it is a big part of the MMR vaccine. Okay, thank you, Tara. Back to you.
Thanks, Liz. And can we have the next slide, please, Emily? So despite Andy Wakefield doing his best to change views on the MMR vaccine and link it to autism, actually nurses and doctors still feature very highly in this veracity index, which is the kind of list of professions that the general public trust most to tell the truth. Pharmacists aren't on there, but I'm assuming that that's because just because they were asked about pharmacists, and that actually because we've got nurses and doctors there, I'm going to say healthcare professionals still have the trust of a lot of people, which is good, because actually what studies have found is that a critical factor in shaping parental attitudes to vaccination is the interactions that parents have with healthcare professionals. And again, I guess one of the things that we should acknowledge here as a potential barrier to vaccination is actually whether we have time in obviously all of us working in the NHS are incredibly busy, incredibly time poor. So do we have the time to be able to spend with families, talking to them and listening to them about their concerns? And I very much hope that with this project, this is the start of families having the opportunity to ask more questions and to express their concerns. Next slide, please, Emily. But then, so what is our role when families come to talk to you in your pharmacy about their concerns about vaccination or their feelings about previous experiences? What is your role? So is it to impart all the information that you can talking at the person in front of you, or is it to maybe listen to their concerns, maybe help them to shine a light on the different sources of information? Is it the information that they've heard at the school gate? Is it what their parents have told them about, well, there was definitely a study, or I didn't have you vaccinated because there was a link between the MMR vaccine and autism, to help them to be able to decipher all the information that they're hearing, reading, and be able to think about what's fact. So then to be able to come to a place where you can use the resources that Christina was showing you at the beginning to be able to present very clear facts. Because I guess what we want to do is enable parents to make a decision that's right for them based on as much correct information and reduce myths and false information. Next slide, please, Emily. Because actually whether to vaccinate your child is still a parental decision when we're thinking about young people under the age of 16, certainly. Some of you might have heard of this, maybe not. It's the zone of parental discretion, and it's an ethical tool for decision making. When maybe that there's discrepancies or differences between a healthcare professional position and a family position. We use it quite a lot with children with complex needs, but I think it applies really well to vaccinations as well. So basically what it will say is that actually there are certain decisions that parents can make, even if the evidence points to the opposite. So for example, I can choose to put my toddler on the back of my bike and cycle around central London without putting a helmet on my child's head, even though we all know that the evidence is if we are then involved in a road traffic accident, my child without a helmet is at much higher risk of a serious head injury. I can choose to take my children out of school and homeschool them, but I can't choose to deny them access to education completely. And we know that actually vaccinating the children will, as Liz has already told you, give them really good protection against some of these really serious and nasty illnesses, but it is still within the zone of parental discretion to make that choice. Vaccines are not mandatory in this country for children. So I guess it goes back to the last slide. It's helping parents to decipher all the noise, all the information that they're getting and they're hearing, and other people's views and experiences, to be able to make the best decision that they can. Next slide, please, Emily. So I just want you to think back to some of those quotes that I had on another slide about actual things that people might say to you. I've heard it causes autism. My friend or my auntie or so-and-so told me that their child was definitely fine until they had the MMR vaccine. Whatever it is, whatever they're hearing, what is going on behind the words that they're saying? Because let's face it, if people want to be difficult about something, there are probably other things to be difficult about. And as Liz said, and as Liz really beautifully described in her own story about having to make decisions about her son's vaccination, she used the word, I was really worried. I became incredibly anxious. And for the vast majority of parents, the children are the most precious things in their life. And they are quite often feeling very scared when we think about vaccinations. So on one hand, they're hearing in the news 9 babies have died this year of whooping cough, or measles is on the rise, and actually many children who get measles will need to go to hospital. There's this awful encephalitis that can happen. You know, they're hearing all these things, and at the same time they're hearing the autism story, or just the constant over you know, people saying you shouldn't be giving your tiny child, so many vaccines all in one go. And actually what happens is they're just frightened of both. They become frightened of the illness, they become frightened of the vaccine. Already talked about the issue of trust, that sometimes it's really strongly held beliefs, sometimes it's just a complete misunderstanding, and sometimes it's just not knowing about the kind of service and how to access vaccines. And as you will all know, across Southwest London, we serve really diverse population. Many families will have come here from other countries. They're having to, as Liz said, navigate a new vaccine schedule that might be different to the one that they've come from. Some of them won't even know that that vaccines are free. And again, I think we could also add that, you know, life is difficult for a lot of people at the moment. And is this a priority? Is vaccinating their child a priority when maybe they're struggling with things like cost of living or other things? Moving on to actually how we might have conversations with people. If you could show the next slide, please, Emily. There can be a temptation when we're tackling something like the MMR link to autism to want to bust myths. But actually, I've been doing quite a lot of work around with a communication charity in my palliative care role, trying to change perceptions of children's palliative care. And until I worked with the communication science experts, I used to myth bust. So I used to say things like, or try to myth bust. I used to say things like, well, children's palliative care isn't just about death and dying. And actually, the science says if we try and myth bust, the MMR vaccine doesn't cause autism. What you end up doing is repeating those words, and what your brain starts to hear is the MMR vaccine and autism, the MMR vaccine and autism, and misses out the words in between. So actually, when we try to bust myths, it can actually be counterproductive, and it can actually make those beliefs about false information feel more real. So instead of saying the MMR vaccine doesn't cause autism, a much better way to lead is the MMR vaccine is safe. The MMR vaccine is one of the most researched vaccines in the world. Would you like to tell me what your concerns are? So we're allowing the conversation to happen, but resisting the temptation to bust the myth and repeat those two awful words together, MMR and autism. Please, could you show the next slide, Emily? The other thing that I think might be helpful is thinking about different parental positions on vaccination. Now, I show this slide with caution because it was from 2012, and we know that the world was a very different place in terms of vaccinations and attitudes towards vaccination and vaccine apathy prior to COVID. So these figures may have changed, but it helped me to understand that there are broadly 5 different positions when it comes to parents making decisions about whether to vaccinate their child. I I guess I used to think in a much more binary way that people either will vaccinate, or no, they were anti-vax. It probably was just me, because that sounds a bit silly now I say it, but we might want to tailor our approach when communicating depending on the position that the parent is in. So this paper found that 30 to 40% of parents are unquestioning acceptors. That's me. Okay, so I don't want to read all the evidence looking at the vaccine trials. I'm quite trusting of the science, and I will accept vaccines unquestioningly. The risk with people like me is that people like me can be quite hard to consent properly, because obviously you need to still tell me about the vaccine, about potential side effects, and I'll be saying, yeah, don't worry, just get on with it. And actually you need to slow some people down in that group, the unquestioning acceptors. Going right to the other end of the spectrum, the anti-vax people that we refer to as anti-vaxxers, but the refusers, back in 2012 were actually less than 2% of the parental population that was studied. It may be a little bit more now, but actually a very, very small group of people who have absolutely non-negotiable reasons to not vaccinate their children. They are not going to budge. It is absolutely a fundamental belief. And then in the middle, varying kind of estimates of how the percentage of the group that each make up, we go from cautious acceptor to hesitant to late selective vaccinator. Cautious acceptors we might never really know about, because they are the people who maybe, like me, I've got teenage children, the invitation to vaccinate their children will come via email. They may actually be really quite worried about the vaccine, but actually nobody's given them any chance to ask any questions. It's come via email. The school team are going into school. They're worried about the vaccine, but then they're also worried about the child not being vaccinated, and they've heard stories about the illness. So actually they sign the form. So they go ahead and accept the vaccine, but they did have reservations. The hesitant and late or selective vaccinators, we will be able to spot. They are the people who won't come the first time, or who might be asking the questions, well, can you split the DTP vaccine? Because I've heard polio's in sewage in London, so I want that vaccine, but I don't want to give 3 vaccines. Or I'm worried about measles. I've heard that there's a rise in measles, but I don't want to give the MMR vaccine. And as Liz has disclosed herself, you know, she at one stage in her life, because of real and genuine concerns about her son, was in that category of feeling scared and wanting him to be protected, but equally not wanting him to have the MMR vaccine. So these are people that might come late. They might be people who present in your pharmacy having missed the MMR vaccine for their child when they were meant to have it in terms of the routine schedule, but who are starting to worry now because of what they're hearing on the news. Thank you, Emily. So just before we think about communication in a bit more detail, just to go back to basics really, and remember that actually only 7% of what we communicate is understood is via words. So actually, again, if we're inviting parents to attend vaccination appointments for their children, and the invitation comes in text or in email or in letter, then we're missing all of the other parts of communication that we might be able to use when we're face to face with someone, and some real basics of communicating, particularly when we're having conversations around challenging topics or topics that can be really emotive. Just basic rules are listen, and listen, rather than launch in with kind of facts or conversation or things that we want to communicate. So really take the time to listen. And it can be really hard if we're under pressure because of time, or because we might be worrying about how we're going to respond. It can be really hard to actively listen, because and I absolutely find myself doing this all the time. I'm listening and then starting to form my response, rather than really listening to understand where that person is coming from. And then thinking about how we try to understand the feelings and thoughts of parents in terms of vaccination. Emily, if you could go on to the next slide, please. A much more recent study at Bristol really focused on the use of empathy in having conversations around vaccinations, not specifically with parents, but with participants, with adult patients as well as parents. So rather than kind of thinking, right, we've got to head straight into this and confront these deeply held views head on and tell them what the facts and the science says, start by trying to understand, actively understand what their own their experience or their point of view might be. So when we think about empathy, we can think about cognitive empathy, so trying to understand their thought process, trying to understand the things that they are thinking about vaccine, and affective empathy, we're trying to understand how they're feeling about that. So I guess that, that's what we've talked about. What are they saying? They're saying that the MMR vaccine causes autism. They've heard that. And then what do they feel about that? Well, of course, they feel frightened. Somatic empathy, I suggest we don't really need in the context of vaccination, because that's really when we're trying to feel the feelings that other people might have. But what they did find was actually using this approach and really trying to understand patients' feelings, values, and concerns really built trust and understanding, allowing then the professionals then to share facts about the vaccination, because they took the time to understand the patient before they gave the information. Next slide, please, Emily. So going back to these different kind of parental positions, that paper concluded that in all encounters, health professionals should build rapport, accept questions and concerns, and facilitate valid consent. But then they came up with more specific approaches. So for those people that were hesitant or late or selective vaccinators, time is the most important thing. And again, I'm acknowledging that actually we don't have a lot of time in the NHS, but if we can offer time, and I certainly have found when I was in the mass vaccination centres that I would say to people, actually, we'll use this whole appointment just to talk, and actually we won't be vaccinating you today because I can tell that you need some more time to think about this. So almost taking vaccination off like that, because I used to think sometimes they thought that I was entering that conversation with them just with the goal of getting that vaccine into their arm, rather than with the goal of really trying to understand what they were worried about. And always asking permission to discuss. So is this something that I can talk to you more about? Is there something you'd be happy to tell me more about your experiences or your concerns? And then is it okay now if I share some of the information that we have? And obviously you have that on Pinnacle. It's also really, really important to always ask what else. So if you say to somebody, what are you worried about? And they say autism, and we just give them the information about autism and then ask if we can vaccinate them, we haven't given the opportunity to actually say, actually, there are a few other things I'm worried about. So really making sure that we've given people time to express each concern and address each one. Next slide, please, Emily. And as Liz said, you will get a copy of these slides. But I'm really hoping that we have some time for questions and discussion at the end. With that very small group, let's say it's around 2% of parents who are absolute refusers, Some of the things are the same. So ask permission to discuss. But obviously be friendly, be professional. But I would suggest that in a world where we have limited time and limited capacity, that is probably not the group to be spending a lot of time or energy on, because their reasons for not vaccinating are non-negotiable. And it can be very easy to get into a game of scientific ping pong where they will say, well, they've read this study and there's another study that said this, and there's another study that claimed everything was false, and we can go backwards and forwards. And in that time, we could have had really meaningful conversations with a much bigger group of people who really needed to to be able to have time to express their concerns with a view to potentially going ahead with vaccinating. I think the next slides I'm not going to cover but they're more there to go through as handouts. If you could just go on to the last slide, please, Emily. I think everything there we have covered through talking, but please feel free to read when you get the slides sent to you. If you're able to use that QR code to provide us with feedback on the training, that would be really helpful. And then with the last the amount of time we've got left, it would be really good to hear some of your thoughts, comments, disagree with what we've said or what I've said, ask any questions.
I've just put some information in the chat there about the chickenpox vaccine, because there's been a couple of questions just whether or not that is going to be added to the childhood immunisation schedule. So I've just popped that in the chat, the information that I know, but I think it is something that we're waiting to hear about.
Thank you. So any do you want to stop sharing now, Emily? Hopefully everyone's got the QR code. Any comments, questions, reflections? None at all. I know it's hot and I know it's late, but anything? Yes. Do you want to, if you've got your hand up?
Yeah, it's actually for Christina. How long is this service likely to carry on for? Sorry, the name is Vandana Patel.
Hi, Vandana. So the intention is for it to run for 6 months, to possibly December, January time. But yeah, that's the aim. So maybe 6 months running time.
And do you expect, sorry, Liz and Tara, do you expect there to be significant education in that time, or sufficient to prevent a significant amount of vaccine hesitancy?
We can hope so. That's why I feel that that's why I sort of was quite I emphasized at the beginning that the quality of these conversations are really important. It's not so much as let's just fill out the template, but it's really having that in-depth conversation with the pharmacy and really trying to with the parent rather, and really just trying to understand why, and just sort of alleviating their concerns, making them feel safe and reassured. So I would hope so. We're trying a different angle.
Perfect, thank you.
And there is good evidence, there's the studies that I've shared. There is good evidence that a change in approach in communicating with families can make a real difference. It's just that we also know that is can be difficult for us to adopt because of the way that life is for us professionally in terms of timing and capacity. Liz.
Yeah, I just wanted to ask Christina, the template that's been put together for the pharmacy staff to use, who actually put that together? Did you put that together, or is that a national template that's been sent out?
I put it together.
Yeah, I mean, it's amazing. The the knowledge and the information that's there at just, clicking on this and clicking on that. So, if you can't remember information about the vaccines, or you don't remember side effects, or you're concerned about whatever, I mean, I think it's fantastic, to have all of that knowledge there, because you don't have to just read it out, but you can look at it and then hopefully think, oh yes, right, that has prompted me to remember this, and have a conversation that's appropriate. I think it looks amazing, and each time we do this I kept thinking, where's that template come from? So yeah, looks good. Well done, you.
Thank you. Nisha and Amit did sort of help, and Dina, we've all sort of tried to cobble it together and make it look nice and presentable without overwhelming everyone. And I know it looks really long, but actually it really isn't. We've tried to keep it nice and compact and concise for everyone. So I hope you guys find it useful. Happy to listen to any feedback as well, good or bad. We'll take it. Thanks, Liz. I appreciate it.
Anything else? Maybe Emily, would you just maybe share that QR code again, just in case anyone hasn't managed to get that link to the feedback form?
Yeah, that's fine. I'll put the link in the chat if anyone
great.
wants to get it
Lovely.
from there
Thank
instead.
you.
Might be easier
so
than the QR code.
Okay, perfect. Thank you. Any other comments or questions? Okay. Right. Well, thank you very much for attending and for your time. Please do fill out the form. It won't take very long, and look out for the slides that will be emailed to you, and enjoy the rest of what's left for your evening.
Thanks, everyone.
Thank you.
Thank you, everyone, for coming, and enjoy your evening. Thank you.
Thank you.
Thanks,
Nisha. Thank you.
Bye.
Bye bye. Bye bye.
Do you want me to stop the recording?